Sparse. देखो आओगा खराब मेरा आओ तो देखो चेयर खींच के लगाओ आओ देखो देखो पहले देखो आओ आओ ना नहीं
Very good afternoon. Welcome to all participants for day 4 session. Really very fortunate to have such a experiential personality in front of us. Even last session we had wonderful interaction and information and knowledge we have gained. Even Rakesh Garga sir is very busy. We know it. AIMS means AIMS New Delhi is it's a government hospital, but even though we usually hear the news, all hospitals are all political leaders and entrepreneurs will join such hospital to take the treatment. You can imagine such a busy schedule. Sir is engaging with us, taking session and sharing his knowledge. Now I would like to call upon Dr. Lavanya to read the profile of Rakesh Garge sir.
Good afternoon, everyone. It's my
Okay.
privilege. It's my privilege to read the profile of Dr. Rakesh Garg, sir. And first of all, happy Diwali, sir. And sir, Rakesh Garg, sir, has done MD in anesthesiology, senior residency in AIMS, New Delhi, and is currently working as an additional professor in anesthesiology, critical care, pain, and palliative medicine, AIMS, New Delhi. Sir has total of 250 publications, both international and national. And sir is the secretary of ISA Delhi and also a council member for ISSP Delhi chapter. Sir is the executive member RSACP from 2018 to 2021. Sir is the vice president of AIDDF from 2019 to 2021. Sir is the editor of PubMed Index journals and also editor in chief of Journal of Anesthesiology and Clinical Pharmacology. And Sir is the editorial board member of 12 international and national journals and a core member for the formulation of guidelines like IRC, CRS, HIPEC, SOAPC, ISA, NELS, etc. Sir has won many awards and many international and national awards. Sir has bagged 2018 Albert Nelson Marquis Lifetime Achievement Award and Pablon's Peer Review Award 2017 for outstanding performance for review of manuscripts. Sir has bagged ISA Proficiency Award in 2019 and also ISA Bhopal Award 2018 for academic excellence. Sir has selected as top 100 health professionals 2017 by IBC Cambridge, England. Sir has received Outstanding Scientist Award for contribution and achievement in anesthesiology. And Sir has bagged second prize for SNJ Best Research Paper Award 2011. Thank you, sir, for giving me this opportunity. And I invite you to start your session, sir.
Thank you, Lavanya.
Thank you so much, sir. Thank you so much, madam, for the kind introduction. Sir, can you allow me to share the screen, sir?
Yes, sir, you can share now.
So thank you so much. I think I must congratulate the whole team for wonderful ongoing academic event. I was just listening some of them, a wonderful session, and
Yes, sir. We
so
are experiencing the experiential knowledge really, sir. Morning, Ganapati sir, and really we are wondering in emergency care, this much knowledge is we did not expect. Just we are working in casualty department or pharmacy students. We don't know, sir. Patients are coming and going. This much depth even we did not find in general medicine, other departments, sir. So we are
So
very
I think,
fortunate to have you, sir.
thank you so much. So I think I'll be taking two sessions today, basics in surgical trauma care and core aspects of bites and stings. So I'll take you through the uh, basics in surgical trauma care, which is a very common but neglected area, and each one of us should know about it because this is the golden period, golden time, wherein if the patient is given a good quality care, the survival chances are much better. So greetings from my place. We have a dedicated trauma center as well, which is running catering a large group of population for managing the surgical trauma. So I need to acknowledge because I am the ATS instructor. So majority of things which I'm going to teach you are primarily based on the advanced trauma life support with some inputs at how acute care in the trauma patients, surgical care needs to be provided in the beginning so that the outcome becomes much better. Now, these are the common scenarios that we see at times. Say, for example, 44-year-old male driver who crashed head-on into the wall, or sometimes a road traffic accident, and these patients may be unresponsive at the scene of accident. Are shifted to the hospital with basic life support and cervical collar, which is desirable for all the trauma victims. The patients may require some amount of respiratory support also. So this patient was receiving ventilation using bag and mask. Now, when we see these type of trauma victims, this was just an example, and there can be a number of examples that happen on Indian roads. when we see the sequence of priorities in assessing these patients, what need to be considered is, do we need to identify specific injuries before initial management of this patient? If not, how do we proceed basically? So, I mean, whenever these patients comes to us, there are two aspects. One are the specific injuries that needs to be looked for. For example, say a patient has splenic rupture, patient has say a pneumothorax, patient has a bleeding wound in the abdomen or maybe in the limbs. On the other hand, do we need to have an overall basic assessment and management for these patients and subsequently go for definitive care? So this is the basic principle that we need to look for. Now, this is the first important principle that because the patients is coming for the first time, in India, we may not have medical records for these patients. So the whole team of healthcare workers to take standard universal precautions for managing these patients. Have a cap, gown, gloves, mask, shoe covers, protective IVR face shield. So these all must be used, and this becomes more important nowadays because of the ongoing COVID pandemic, and hence all precautions, standard universal precaution must be taken by all the healthcare team while this patient is being managed. Now the first aspect remains the initial assessment of these patients, and this is labeled as primary survey. So when we do a primary survey, we have to look for the assessment parameters of the more vital functions that are, if not managed in the initial few minutes, they can have disastrous outcome. And whatever the findings that we want, we need to resuscitate so that the patient's vital functions are maintained. And this usually is in the form of a team approach, because especially when you are in the hospital, you will be having a team, and that's why the call for help is one of the important aspects. And hence, we should be calling the team who is taking care of these trauma victims, and hence we need to manage them as a team approach. Now, this is how we talk about the initial assessment, that is the initial few minutes that we are talking about these patients. This should be the flow of these patients. So whenever we are going to receive a patient, we should prepare ourselves along with the infrastructural things when the patient is coming to a center with trauma, because sometimes there could be a call that trauma has happened and this number of victims are coming to the hospital. So you be prepared accordingly depending upon the number of victims you have, and then start with primary survey, in which as and when whatever issues are happening in the primary survey, you need to correct them, resuscitate the patient, and various adjuncts can be used. I'll come a little later. And then these patients sometimes may deteriorate in subsequent period of time. For example, a patient is having small simple pneumothorax, but if they are started on positive pressure ventilation, if the patient is not breathing, the small simple pneumothorax can be converted into tension pneumothorax. And hence, it is very, very important that the dynamic clinical situation of the patient should be re-evaluated in these patients, so that if a patient deteriorates, or in case if it is improving, it gives reassurance that your technique is ineffective or you have missed something, or if it is improving, this means that whatever plan of management you are doing for these patients appears to be okay. So once the initial core vital system has been looked for, heart, kidney, brain, respiration, which usually form in the form of A, B, C, D, E also. I'll come a little later in more details. Then subsequently you go for detailed secondary survey. And then finally definitive care may be done. And again, even during the secondary survey, you have to reevaluate these patients at frequent interval of time. The timing is not defined. It depends upon the patient condition. And according to the evaluation, you need to intervene, resuscitate, and try to optimize these patients. Now, whenever the patient comes to us, time is an essence. So this means we need to assess these patients very fast. We cannot wait for various investigations or imaging like CT scan, and then you say that we will take care of these patients. We need to assess this patient. And if I ask you what is a quick, simple way to assess patient in 10 seconds, if anybody wants to answer it, they can answer in the chat. That shall be good. So this means when we say quick assessment, the best way is you ask the patient, ask the patient his name and ask him what happened. So if the ABC is okay, airway, breathing, circulation, and neurological function is okay, he will have some purposeful response. So this means just asking the patient name and the clinical situation, it will help you to see that the patient is having some gross issues or there is some minor issues, otherwise the patient appears stable. So that's why just asking the name and what is happened to the patient, how the injury happens, will give you a fair idea that the situation of the patient is how much grievous it is. Now, so this means this response, because when we verbalize, we need to have a patent airway and sufficient airway reserves in the lungs to permit lungs. This means A and B is okay. If the patient can perceive you that you are asking something and can understand, this means the brain perfusion is happening okay and the sensorium is also clear. So this means ABCD of the patient, by asking simple question, it confirms that there is no major issues right now with the ABCDE. And this is what we remember for the primary survey. Now this is what I was saying to you: A, B, C, D, E. Airway is airway with C spine protection. B is breathing and ventilation. C is circulation with hemorrhage control. D is disability, that is the neurological status. And exposure and environmental control, like for example, say patient is having some limb deformity, the outside temperature. So all those needs to be looked for in this. So when you do a primary survey, you need to have a quick evaluation of life-threatening events in the primary survey. And the priorities remain same for all the patients, irrespective of whatever trauma has happened, whether it's to chest, abdomen, or lower limb. The priorities will remain the same, and you need to follow the principles of A, B, C, D, E, A here. However, in certain group of population like elderly, infants, pregnant women, obese, and athletes, the patient manifestation may be a little different, and hence while you are assessing these patients, you should be cautious for assessment of these patients. Now coming to the first part of primary survey, ABCD, when I mentioned airway, the airway should be patent, right? You need to establish a patent airway. And in trauma victims, we need to assume that they may have C-spine instability or fracture. And hence, whenever you manage the airway, because the airway leads to movement at the neck, that is at the C-spine. So you should be taking care of the C-spine. So you need to apply the cervical collar. And during airway management, you can remove the cervical collar, but with the application of manual inline stabilization, so that further injury to the spine is not happening. You should be careful about the various pitfalls while you're managing the airway, because sometimes the airway injury may not be so obvious. There could be a progressive loss of airway, there could be equipment failure, or there could be a difficult airway. Hence, you should be cautious while you are managing these patients. Also, while managing the airway, you should look for sometimes the trauma could lead to the airway difficulty itself, and that will lead to some issues while you're securing the airway in these patients. They could be because of many injuries that can happen to these patients. The patient may be in prone position and hence the airway remains inaccessible, or it could be a direct maxillofacial trauma, and hence you should be very careful while you're managing these patients. So this means these patients could have anticipated difficult airway, or it could be unanticipated. And sometimes these patients may be in C spine collar, or they are fixed to the spine board, and hence the mobility of the neck is absent, and hence the airway may be potentially difficult. Also, simultaneously, you need to remember that the patient cooperation may not be so good, maybe because of patient pain, anxiety, and so on and so forth. Also, at times, patient may be hemodynamically unstable, and any patient can reach to or further aggravates this hemodynamic instability. Now, the various trauma that can be seen in this patient can happen to various aspects. We should be assessing these airway, but since I mentioned that trauma victims cannot give you time, and hence the assessment time for assessment and reassessment, so it should be done quickly. Whatever radiological them, also simultaneously ensure that the patient's C-spine injury is taken care of by avoiding any type of movement at the neck, and pain should also be relieved in these patients so that the patient is comfortable. Now, you need to appropriately for airway management. Look for whether the other components are okay, and look for whether the patient pain, neck movements has been taken care of. Also, at times, these trauma victims may be having an airway which could have been secured outside, but while these patients are moved to the hospital, they may have certain displacement or dislodgement of this tube. The various devices that are used outside the hospital could be supraglottic airway devices, combi tube, and at times somebody would have intubated them also. But remember that these devices which has been put outside the operating room, outside the hospital, they may be inadequate, they may be displaced or misplaced. Since the patient is having bleeding, they could be blocked by mucus, blood clots, and hence these complicated situation needs to be reviewed when these patients present to you inside the hospital. Also, as I mentioned earlier, these patients could have pneumothoraxis, or maybe that the tube is kinked, blocked, and hence you should use this mnemonic to ensure that the airway is patent even with these equipments that has been placed in these victims of trauma. So once the airway has been secured, you need to look for these patients to look for the breathing and ventilation. And herein you need to assess and ensure adequate oxygenation and ventilation. Once the airway is patent, then you need to look for the respiratory rate, the chest movement, air entry, and oxygen saturation that will ensure that the patient is appropriately breathing with good ventilatory efforts. So this is important when you are managing these patients. But remember that because as I mentioned that these patients could have airway issues as well as ventilatory issues. As I mentioned earlier, that a small simple pneumothorax but with airway management and positive pressure ventilation, this may be converted into tension pneumothorax, and hence it is very, very important to reassess these patients timely before they collapse. Now, once A and B are taken care of, you need to come back to the circulation, and it also includes the control of the bleeding, hemorrhage control. And when we talk about the circulation, you need to assess for the organ perfusion. How can we look for the organ perfusion? You need to look for the conscious level, look for the skin color and temperature, the pulse rate, and the character. Pulse is one of the earlier marker of bleeding, hypotension due to hemorrhage, and hence the increased pulse rate will be an early indicator of patient having bleeding and circulatory compromise. Hence, you should be looking for these parameters in the primary survey. And whatever parameters that you get are deranged needs to manage. If patient is having some bleeding, simultaneously the attempt should be made to control the bleeding as well. Once the bleeding is controlled, you need to restore the volume. You can use the crystalloids, which remains the important fluid for these patients. Try to replace them with fluid, secure a 2 large bore venous access in both the upper limbs, and try to infuse around a liter of crystalloids to these patients and try to see for the response. Remember, when we are giving fluid to these patients, you should also be ensuring that if there is source of bleeding, external or internal, should also be taken care of, and the bleeding should be controlled. If the external bleeding, it can be controlled with pressure. If the internal bleeding and the patient remains hemodynamically unstable, these patients may require operative intervention. Now coming to the fourth ABCD disability. Disability means primarily the neurological functions you need to look for. Look for the baseline neurological evaluation, the Glasgow-Coma scale, and the pupillary response, and look for whether they are having neurological deterioration, which can happen because of hypoxia, because of the circulatory compromise, or primarily because of the neurological injury, the brain. You need to assess these patients by having a baseline neurologic evaluation and subsequently keep a follow of them, whether this neurological functions usually assessed in the form of DCS, whether they are improving or it is stable. The last step in the primary survey, A, B, C, D, E. E stands for exposure and environment. Completely interest the patient and look for that whether there is any other injuries that is present to the patient. But at this point of time, when patients are removed, these patients can have hypothermia, and hypothermia has a lot of impact on the body. It can lead to organ dysfunction. It can lead to coagulopathy, and hence, once you are exposing the patient in a cool environment of the area, you should be careful. Patient should be immediately examined and covered back. The OT temperature or the emergency room temperature should be increased. And these patient, if there is no injury, they should be covered back with blankets or warmer blankets so that the patient remains stable. Now, once these things are done, you need to resuscitate, and this should be done simultaneously. When we say primary survey, we don't have to do ABCD and all the assessment and then start treating ABCD again. You have to do it simultaneously. So this means you protect and secure airway, you ventilate and oxygenate, you stop the bleeding, give the bloods or the crystalloids, and protect the patient from hypothermia once you examined it. So this should be done simultaneously while the primary survey is being done. Now there are various adjuncts that should be done along with the survey that will give you the overall idea of this trauma patients. Apart from noting the vital signs, you can put up various catheters like urinary or gastric catheters, and when they're contraindicated, especially if there is a thoracic injury or abdominal injury or a brain injury, you should be careful. Or maybe a bladder injury, you should be careful. Otherwise, put up a urinary catheter and decompress the stomach, putting up a gastric catheter. Urinary catheter has an advantage because urine output is one of the very good index of the optimal perfusion, and hence a good urine output will give an indication that your resuscitation, ongoing resuscitation is good. Also, you can attach the pulse oximeter and the capnography to these patients to look for whether the airway and breathing is okay. ECG may be attached to these patients to look for the cardiac arrhythmias, which can happen sometimes. ABG analysis needs to look for various respiratory and metabolic components so that it will give you an idea that what type of organ abnormality is happening to these patients. Also, in trauma patients, we usually order for 2 X-rays, one chest X-ray and second pelvic X-ray, because both has a potential of injury and both can lead to catastrophic outcomes. Tension pneumothorax I mentioned one, hemothorax can happen, abdominal bleed can happen, pelvic fracture is one of the notorious wherein a good amount of bleeding can happen to these patients and they can bleed to death. And hence, identifying these type of pelvic trauma is very, very important, because if you identify them, just simple measures like pelvic binder would be helping us to take care of these patients and control the bleeding. Nowadays, the use of ultrasonography is one of the very good option to do it as a point of care ultrasound in the emergency room itself, and they can identify the various injuries, including pericardial tamponade or bleeding in the abdomen, maybe because of kidney injury or blood injury or other type of injuries, and hence fast can be done to identify these situations. Even the extended fast has been used to look for the chest and the peripheries also for any type of other injuries, even including fractures. Now, when we talk about the primary survey, and if you identify that patient is having some critical issue, we should not delay transfer for diagnostic purposes, and the time before transfer for resuscitation must be appropriately done. We should not be sending these patients for imaging modalities unless they have been optimized. And at times, these patients may be not required to be shifted to higher center for definitive management. But if you have the facilities at your center, you can go ahead and do other interventions, maybe like laparotomy or tracheotomy for management of traumatized structures. Now, when we say once the primary survey has been done, which is primarily looking for the life-threatening events, and they have been stabilized, now try to look for other events which could be potentially life-threatening if they are not managed in time, and that are covered in the secondary survey. So this means I'm very clear here that in trauma victims, you need to look for the primary survey, identify the life-threatening injuries and try to optimize them, and then go for looking for other injuries which may have the potential to become life-threatening or limb-threatening, and then try to identify them in secondary survey, which is primarily a detailed head-to-toe examination of the patient. Now, once the primary survey is completed, ABCD is reassessed, as I mentioned earlier, re-evaluation, whether they have responded to your treatment intervention or they have not responded. And accordingly, if the vital functions of the patients are started becoming normal, this means they have responded well, and then you can start on to identify the smaller injuries. The components of secondary survey includes the history from the patient or the patient family members. Also, you need to have physical examination from head to toe, complete neurological examination, special diagnostic tests like CT scan, X-rays, or ultrasonography, and then simultaneously you need to reevaluate this patient that whether they are improving with your management or they are deteriorating, or some new finding is there which necessitates management. Now, in the history, you need to look for various things like allergies, medications, like sometimes the patient may be on beta blockers, and because of this beta blockers, these patients may not show tachycardia, but they may be having bleeding somewhere. Some of the signs were confronted. The patient may be on anti-epileptic, patient may be on bronchodilator. So you need to ask from the history, from the family members about these medication and the past illnesses or pregnancy, last meal, because these patients can regurgitate and aspirate. So that's where the last meal and the events, environment, and mechanism of the injury, that how it has happened, whether he was drunk at that point of time, whether there was seizures, whether there was a chest pain, or what situation happened, whether it's a dangerous mechanism of injury or whether it was something else. So this means all those events needs to be identified in these patients from the history elicitation. The mechanism of injury is one of the important aspect because, for example, say a car travel collided with another vehicle, the co-passenger died. This itself shows that the injury was very grievous. The mechanism was very grievous. So based on this, the mechanism itself will indicate you the gravity of injury, and hence these patients would require very close follow-up apart from examination or diagnostic test. Now, starting the secondary survey from head to toe, in the head you look for external examination, the skull palpation for any bleeding, look for the eye and ear examination for any bleeding, collection of blood there, or bleeding from the ear, which indicates the base of skull fracture. Also see for the visual acuity, look for the brain injury or injury in the orbital fossa. But sometimes the patients may have unconscious, they may not respond to your clinical examination. They may have periorbital edema because of injury itself, and hence becomes difficult to examine these areas, and hence that's why sometimes reassessment is very, very important. Look for the facial structures, the maxillofacial structures, the bony crepitus, deformity and malocclusion. And sometimes because of the head injuries, they can have airway obstruction or cribriform plate fracture, which can be frequently missed if we have not done detailed examination for these patients. Look for the soft tissue injuries in the neck, because sometimes when these patients have bleeding in the neck, initially they may not be compromised to the airway, but with bleeding, with increasing hematoma, they can have compromise to the airway, venous congestion to the head and neck area, and hence these patients can have deteriorating neurological or airway and breathing status, and hence you should be looking for and reassess these patients. Look for whether it's a blunt versus penetrating injuries, whether there are signs of airway obstruction or hoarseness, whether they are crepitus, hematoma, stridor, or bruit. And sometimes these symptoms are slow progressive, and hence the reassessment of these patients are very, very important. On the chest, follow the in the secondary survey, follow the norms of inspection, palpation, percussion, and auscultation, and then review the X-ray also to look for the various eye findings. There could be any injuries in chest like pneumothorax or bleeding, and hence needs to be assessed. Now, coming lower down in the abdomen, again needs to look for the inspection, auscultation, palpation, percussion, and then reevaluate. But remember, the ultrasonography has become one of the important parameters. The FAST or E-FAST now is an emerging tool in these patients to identify the intra-abdominal injuries. Sometimes they may be missed. That's why the reassessment of these patients and response to your management is important. Look for the any contusions, hematomas, lacerations, urethral bleed in the perineum that are indicative of rectal injuries or blood injuries. And for rectal injuries, look for sphincter tone, high riding prostate, pelvic fracture, rectal wall integrity, or blood in the perrectal examination, or presence of blood and laceration in the vagina. So these injuries also needs to be looked for in trauma patients because they have, if they are managed on time, the patient's outcome becomes much better. The pelvis, as I mentioned earlier, these patients may have pelvic fractures, the trauma victims, especially when they have fall from height. So the pelvic fractures leads to a lot of blood loss. So that's why you need to check pain on palpation. The leg length is whether equal or unequal. Check for the pelvic compression test for instability, and X-ray may also be done in these patients. But do it only once because repeated doing can lead to more of a bleeding in these patients, and hence the excessive pelvic manipulation must be avoided. In case of any suspicion, you can get an X-ray done to confirm whether there is a pelvic fracture or not, and accordingly you can manage these patients further on. And then finally, in the secondary survey, look for the extremities, all the four limbs, for contusion, deformity, pain, perfusion, peripheral neurovascular status, or in case if there is any suspicion, you can use the X-rays to confirm, rule in or rule out these the fractures. Also look for the muscles, because sometimes the crush injuries, a lot of muscle is affected. Muscles are also affected. They can lead to a lot of blood loss. Sometimes the underlying fractures are missed, and hence you need to assess them, because if they're not managed properly, a lot of edema happens, and this can lead to compartment syndrome that can even lead to loss of the limb, and hence early identification is important. The neurologic examination should be done in detail. Look for the Glasgow Coma Scale score, look for the pupil size, lateralizing sign, and you need to reevaluate these patients, because sometimes a small bleed may not have neurological symptoms, but then when you start resuscitating them, when the BP starts picking up, these patients may have more bleed and they can deteriorate, and hence you need to look for. Similarly, the spine trauma can be seen in these patients, and hence spine assessment, the whole spine should be looked for by looking for any deformity, any tenderness, any swelling. Simultaneously, also look for complete motor sensory examination and reflexes. In case of any doubt, you need to evaluate using imaging modalities for looking for any spinal cord or vertebral column injury. In case if there is any suspicion, you need to call for the neurologic consult and orthopedic consult. In this, if you see, a log roll is being done and the whole spine is being palpated and taken care of. In case if any neurologic examination is suspected, neurologic deterioration or insult is suspected, which is very common in trauma victims, you can see as in picture, they should be on long spine board, nicely strapped using a cervical collar, till you are sure that the neurological injury to the spine is seen after this trauma. Remember that when we talk about the adjunct to secondary survey, the should not delay the transfer of these patients for the purpose of diagnostic modality only. The clinical parameters remains very, very important. Once the has been done, then these diagnostic tests can be done to rule out any other injury. Now, sometimes we miss many of these injuries, so you should be very, very careful. You should always, based on the mechanism of injury, a high index of suspicion, and evaluation and re-evaluation is the key to identify these type of injuries. The pain management is an important aspect, because multi-trauma patients will have pain. They may be elderly patients. They can lead to further insult in the form of a heart attack on all those issues, and hence the relief of pain and anxiety as per requirement of the patient, once you have assessed them, should be provided to these patients. But remember, when you are giving them any drugs, be cautious, because they can have impact on the neurological functions of these patients, and hence properly titrated under supervision, those should be given for any analgesic to these patients. NSAID can cause bleeding, opiate can have some neurological issues, and hence the drugs for pain management should be given appropriately and with constant re-evaluation and monitoring. These patients can have shock because of multiple reasons. Majority of time, the shock is the reason is the hemorrhagic shock because of the blood loss. But you need to look for that. What is the reason? You need to locate the bleeding for the shock, and hence physical examination and use of other adjuncts which I mentioned earlier, like chest X-ray, pelvic X-ray, and use of FAST. That is ultrasonography assessment of the abdominal organs is essential to locate for bleeding, and accordingly you need to manage them. So in case if a patient is having shock, yes, definitely we need to resuscitate them. But then maybe direct pressure tourniquet if it's an external bleeding, reduce pelvic volume by using a pelvic binder, intra-abdominal constant bleeding, hemodynamically unstable may require surgical intervention, use of hemostatic agents like tranexamic acid. If a patient is having a fracture, for example, say femur fracture, which can have least to 1 to 2 liters of blood loss, you can splint the fractures. At times, we also do angioembolization of our bleeding vessels if we are not able to control as a conservative management, as nowadays the intervention radiation can embolize those bleeding vessels and control the bleeding. So that remains the other options for management of bleeding in these patients. And in case if these patients require some intervention, for example, the thoracic surgeries or some major abdominal surgery and needs to be shifted to higher center, it should be done at the earliest, right? Once the patient is initially assessed and stabilized, these patients should be shifted to a higher center for further management. However, the resuscitation should be ongoing in these patients. Now, while these patients are being shifted to higher center, be cautious that they should not be having any ABC issues. And once these are stabilized, the patient should be shifted once you have talked to the patient, family members, and also definitely to the hospital in which you are being shifting this patient, that they have the facility and bed available, and then they should be shifted depending upon the patient condition. So coming back to the same patient, this patient was managed properly, and patients require surgical management to control the issues. Patient was revalidated and definitely care was provided, and patient outcomes becomes good. So this is the overview of patients management when we talk of the patients of trauma victims. And this is very, very important to understand that the time is an essence, and hence the patient should be managed immediately with the sequence of events which I have just mentioned. Now taking you through the second component of today's presentation, the bites and stings. So when we talk about the bites and stings, about the bite and sting, there could be various bites, stings can happen of various things depending upon the geographical area where you are residing, and based on this you can have these types of bites and stings. But the basic thing is majority of time when you're talking about this, they are usually the minor things. They may not be leading to major issues, except in certain situations. They are not emergencies as such. Treatment is usually for bleeding, wound care, infection. But sometimes they can manifest in the form of anaphylaxis and they become a medical emergency. And hence we should be cautious in identifying the situation. And if the immediate treatment is provided, these patients becomes very, very important. So these are the two broad things nicely mentioned by this group of persons, which can go wrong in these patients. Is either an allergic reaction or it could be infection, apart from panic and anxiety that happens to these patients. So the allergic reaction is primarily due to the various mediators which are released, or they are sting because of these bites, and sometimes the infection spreads from the sharp tooth and puncture wounds, and the germs can enter the body, and it can lead to the infection. Now, when we look for the allergic reaction, this manifestation is as per any anaphylaxis. They can have swelling, they can have rapid pulse, they can have rash, they can have itching, feeling sick, feeling dizzy, and subsequently they can have difficult breathing and abdominal pain. So these are the various signs of allergic reaction that needs to be looked for. And when you start managing these patients, always try to protect yourself, call for help, stabilize the patient, and the ABC management remains the important way of managing these patients. Now, most of the animal bites, I may not be going into each separately, but majority of them would require cleaning the wound with large amounts of warm or room temperature water with a good amount of soap if available. Control the bleeding in case they are happening by pressure bandage. cover the wound with sterile dressing and bandage, and then they should be shifted to the hospital so that they can be managed further on. In case if you see a sting from the skin, it can be removed using a key or any hard surface. Wash the area with soap and water. Push ice or cold pack on the area for some time, and then in case if patient is having any other issue, they can be shifted to the hospital for further management and observation. Now coming to the dog bite, the dog bite could be single or multiple bites, and sometimes it could be scratches also. But you need to remember the basic concerns are the infection of rabies and the local wound infection. For these patients, these would require washing them with soap and detergent. Subsequently, these patients can be vaccinated using the rabies vaccine. The immunoglobulin and tetanus toxoid should also be used for these patients. Usually these wounds are not sutured because they can have risk of infection. They should be kept open, nicely washed with soap and water and kept dry. The snake bite, which are commoner in India, but most of the snakes are non-poisonous, and hence the issues are very simple. There are many myths which happens like cutting the wound and sucking the venom, applying a tourniquet, or applying herbal paste. So this must not be done. What needs to be done is you reassure the patient, wash the wound with a lot of water and soap, and take it to the nearest hospital where they can be given an anti-snake venom and tetanus toxoid injection along with the local care of the wound. That is desirable in these patients for good outcome. So thank you once again, and I am open for any questions from anybody of you. Over to you.
Thank you, sir. Sir, this bites and stings, so bees are there, no, sir?
Yes, sir.
Bees and wasps are, if they bite you, sometimes is also leading to death.
Yeah. So at times they can lead to in case if the anaphylaxis happens, they can have a cardiorespiratory compromise along with severe airway and breathing involvement. So that's why these patients require intervention. The use of drugs like adrenaline is very, very important to counteract the effect of the anaphylaxis in these patients, along with other supportive therapies is desirable. So in case if anaphylaxis happens, it becomes a medical emergency, and hence the standard of care should be taken for these bites and stings.
Within the time they come to the hospital, it will be curable. It cannot lead to death, no, sir. Bees are wasps.
Yeah, usually it will not lead to death, but yes, some of the myth happen. Like for example, if somebody has anaphylaxis, somebody will try to give them food, some water, and all those things, so they can aspirate and can have issues. So in case somebody is anaphylaxis, they should be taken immediately to the hospital, and there once they are in the hospital, they may require the airway management, breathing support, and for circulatory collapse, they will be put on certain drugs. And once the effect of the insect bite goes away, these patients will come to normal. So we need to have a supportive management during this period, and majority of these patients, if timely treatment is given, they will come out nicely.
Okay, thank you, sir. Yeah, participant, do you have any questions? Okay, sir. Thank you, sir. Thank you for your valuable time, sir.
Thank you. Thank you so much. Thank you.
I'm ending the session. Thank you, Anandal. Last session tomorrow. We'll meet tomorrow.